Hi, very good morning. So it's been a long while since we had a live session. So from this week onwards, we'll be having live sessions on Wednesday and Thursday as per the new schedule, both morning as well as in the evening, right? And please note the change in time in the evening session where we'll be having live at 8 p.m. rather than 9 p.m. Okay? So I shared some of the multiple choice questions yesterday in our Google group. I hope you have a copy of it. So I hope you have solved them as well. We'll have some elaborate discussion pertaining to those questions and related topics now. Okay? Hope you're all doing fine. And once again, a very good morning. Hi Abhishek, Shilpa, Shiva, Megha, Suresh, Richa, Jeena, Prithvi. Hi. Good morning all of you. Right. So at least try to have a soft copy. I mean, if it's hard copy, it's much better as you can note down points there itself alongside the question. So we'll start with the first question. So I've shared 10 questions overall. So we'll try to complete them off. So coming to the first one, coating of bacterial particles with host proteins to facilitate phagocytosis is known as chemotaxis, chemokine, opsonization, membrane attack complex. So try answering the question. We'll have some discussion pertaining to that. Hi Bernice, a very good morning. So the first question, coating of bacterial particles with host proteins to facilitate phagocytosis is known as. So we have options chemotaxis, chemokine, opsonization and membrane attack complex. So what is this opsonization all about? Hi Nidhi, good morning. So opsonization is nothing but facilitating phagocytosis by coating bacterial products by immune cells. We have certain opsonins which facilitate this process of phagocytosis. So phagocytosis is a chief function of neutrophils as well as macrophages, including giant cells, as you all know. So opsonization is nothing but enhancing this phagocytosis by facilitating, by coating the bacterial cells with these host proteins. And the commonly asked question again is, name some opsonins. So we have, can you name the opsonins? So as it's mentioned, coating of bacterial particles with host proteins. So can you name some host proteins which coat the bacterial cells and enhance phagocytosis? Optimization. What is optimization, Abhishek? Yes. So we have certain host proteins including IgG, which is an antibody, C3b, and even lectins. So these are known opsonins. I hope you can see, right? So IgG, C3b, lectins, they are known as opsonins, right? And also there was another question like name some anaphylatoxins. C3a, C5a. So these are considered as anaphylatoxins. So just make a note of this, right? Yes, Gina. Is it C5b? It's C5. It's C3a and C5a. Yeah. Hi, Purvil. A very good evening for you. Yes. So coating bacterial particles with host proteins to facilitate phagocytosis is known as opsonization. Whereas chemotaxis is nothing but chemically induced movement or movement towards certain chemicals, as we can see in case of phagocytosis where neutrophils or other defense cells move towards the area where certain chemicals like histamine and other mediators are being released, right? Taxis is movement, so it is influenced by chemicals, so chemotaxis. So that's altogether a different phenomenon. Chemokines are various mediators released by various inflammatory cells, as you all know. And membrane attack complex is something which is formed in T cell mediated kind of immunity, right? So option C is the right answer. Hi Tanu. Oh, very good morning. Yes. Okay, I hope it's audible and clear. Right. Now let's have a second question. Second question is nutmeg liver. Nutmeg liver occurs in, we have options: jaundice, chronic venous congestion, cirrhosis, and hepatocellular carcinoma. So what is this nutmeg liver and where does it commonly occur? I mean, nutmeg liver is one form of a systemic manifestation of the given options. It can occur anywhere depending upon the heart, which is, I mean, the side of the heart which is involved. Yes. So nutmeg liver occurs in jaundice, chronic venous congestion, cirrhosis, hepatocellular carcinoma. Exuberant granulation tissue. Basically, as the name itself indicates, yes, it is chronic venous congestion. So there is a dilation of capillaries. There is impaired flow to a particular organ because of congestion. So you can just make a note of this point. Dilation of veins and capillaries due to impaired venous drainage, also called as passive hyperemia or venous congestion. Venous congestion or passive hyperemia. So this is due to impaired venous drainage. Isn't it? So dilation of capillaries or veins because of impaired venous drainage, which leads to passive hyperemia or venous congestion. So we have different kinds of appearances depending upon the organ which is involved. So in case of liver, we have this nutmeg appearance. So what is this nutmeg? Yeah, nutmeg. So what does the term nutmeg? In fact, nutmeg is a nut. It's a kind of fruit. Even in your textbook, they have mentioned, they have shown you the cross section of a liver, which is having this nutmeg appearance along with that fruit. It is called as jayafal, I think, in Hindi. Nutmeg is nothing but a spice which is used. So it resembles the cut surface. I mean, the cut surface of liver resembles that nut. So it's called as nutmeg appearance. So nutmeg appearance of liver. So it is seen in CVC liver, nutmeg appearance. In case of CVC lungs, what do you call that typical appearance, or what do you find in case of CVC lungs? We have, because of this venous congestion, because of passive hyperemia and accumulation of blood over there, there will be lysis of RBC, deposition of hemosiderin in macrophages, and we find a typical characteristic cells in case of CVC lungs. Yes, jayafal. Yes, Gina. Spice, it's a spice. Good. So nutmeg liver is seen in CVC liver, chronic venous congestion of liver. In case of CVC lungs, what cells do you find? And also, in case of CVC spleen, Well, you can try answering this, okay? Yes, nutmeg you will have pale as well as pale yellow as well as dull alternate bands, and this light yellow in color is mainly because of this venous congestion. Moreover, the entire organ has this cyanotic appearance, bluish kind of appearance because of venous congestion. Laudacious spleen or that comes in amyloidosis, right? Amyloidosis of spleen. Laudacious means fat-like. Laudum means fat of a pig. Mat-like appearance. Laudacious spleen or sagospleen, they are appearances in case of your amyloidosis. Yes, good Shiva. Yes, Nidhi. Yeah. In case of CVC lungs, we find heart failure cells. So heart failure cells are found not in heart but in lungs. So heart failure cells are nothing but macrophages laden with this hemosiderin as well as calcium. Whereas in case of CVC spleen, so what kind of cells do we find? Or what kind of bodies do we find? Gamma antibodies, exactly. Gamma antibodies, again, these are accumulation of calcium as well as hemosiderin in spleen. So, venous congestion, passive hyperemia leading to dilatation of capillaries or venules because of impaired venous drainage, and usually right heart failure leads to chronic venous congestion in certain organs, and left heart failure leads to chronic venous congestion in certain organs. For example, as you all know, right heart, it can be right auricle or ventricle, receives venous flow from inferior and superior vena cava. So whenever there is a failure of right heart, then there can be venous congestion in various systemic organs like heart, kidney, spleen, etc. In case of left heart failure, you will obviously have congestion in your lungs. Retrograde. Try thinking retrograde, because your left heart, it receives blood again from your lungs, right? So obviously whenever there is left heart failure, there will be a chronic venous congestion in lungs. Right heart failure, chronic venous congestion in various other systemic organs from which blood is being collected. It can be kidneys, it can be heart, various other organs, right? Spleen, etc. So again we have these typical appearances which are very important. CVC liver, we have this nutmeg appearance. Nutmeg is nothing but a spice. In Hindi, it's called as jaifal. Jaifal, okay. And CVC lungs, we have heart failure cells, accumulation of hemosiderin in macrophages. And CVC spleen, we have gamma antibodies, accumulation of hemosiderin as well as calcium, right? I hope it's clear. So nutmeg liver occurs in chronic venous congestion. Option B. So let's proceed with the next question. So the next question. Coagulation necrosis is seen in all cells except. The question is, coagulation necrosis is seen in all cells except. So we have options: liver, heart, brain and lungs. So coagulation necrosis is seen in all except. So first of all, necrosis, it's nothing but death of a tissue. Programmed cell death is nothing but apoptosis, right? So we have different types of necrosis, as you know. So can you name them? Different types of necrosis. One is obviously in the question, coagulative necrosis. And then we have, yes, liquefactive, gaseous necrosis, fat necrosis, and fibrinoid necrosis. We have discussed different types of necrosis in one of the previous videos. You can refer that for more information. So coagulative necrosis is a form of necrosis where there will be coagulum, like in the sense the outline of the cells will be maintained, but there will be a loss of all intracellular organelle. So yes, exactly. Gangrenous is not considered, gangrenous is a different entity where there is a suprarenal infection, right? So coagulative necrosis, we have this typical tombstone appearance. Just make a note of that point, okay? Coagulative necrosis, you have tombstone appearance where the cell architecture is being maintained even after the death of this cell, isn't it? We'll have image-based questions tomorrow for more clarity. Then, liquefactive necrosis. By the way, the examples where you see coagulative necrosis include various organs like kidney, heart, spleen, any part of the body except for brain, where you see liquefactive necrosis in case of brain. And gaseous necrosis, the best example which you're all familiar with. So we have various granulomatous inflammations like tuberculosis, or it can be leprosy, isn't it? And then fat necrosis in case of a traumatic injury, in case of breast, female breast, as well as acute pancreatitis. Fibrinoid necrosis in case of autoimmune diseases where there is deposition of your antigen antibody complexes, right? So the question is, coagulative necrosis is seen in all except liver, heart, brain, lungs. So usually in case of your brain, and the reason why we see only liquefactive in brain but not coagulative necrosis is the fact that the cells do not have a specific shape or architecture. So that's one reason which has been attributed why we don't see coagulative necrosis in brain. And the second reason which was mentioned in your textbook is that it's unclear why only liquefactive occurs in brain, right? So coagulative necrosis is seen in all except, so the answer is brain, right? I hope it's clear. Exactly. Good. Now let's have another question. The fourth one. Yeah. So the blood in vessels normally doesn't clot because vascular endothelium, I'm sorry for the spelling mistake, it's not enthelium, it's endo. Vascular endothelium is smooth and coated with glycocalyx. Vitamin K antagonists are present in plasma. Sodium citrate in plasma chelates calcium. Thrombin has a positive feedback on plasminogen. So the blood in vessels normally doesn't clot because Yes, Abhishek. Lung, we see caseous in case of tuberculous necrosis, tuberculous kind of infections. Yeah. In tuberculous or granulomatous infections or inflammations, we specifically see caseous. In other kinds of necrosis, which we commonly find, obviously include your coagulative necrosis. Hi Preeti, a very good morning. Because tuberculous infection as such is a kind of entity which mainly stimulates your cell-mediated immunity rather than humoral. So wherever you find, even in case of your lymph nodes, you can have these tuberculous infections, you can have these granulomas, right? So since lungs are being involved, we find caseous necrosis there. But in general, this coagulative necrosis can be seen in various organs except for brain. And also it's mentioned that caseous necrosis has features similar to that of coagulative and liquefactive. Yeah. So blood in vessels normally doesn't clot because. So vascular endothelium is smooth and it is covered by glycocalyx. Whenever there is damage to vascular endothelium, the damaged vascular endothelium, stasis of blood or altered blood flow, so all these three factors are essential for coagulation to occur or for hemostasis to occur as such. So these three are nothing but your Virchow's triad, isn't it? Your damage to vascular endothelium, it can be stasis of blood or altered blood flow, right? We have these three parameters which shows triad. So as long as your vascular endothelium is smooth and is coated with glycocalyx, blood doesn't clot. And make a note of these points pertaining to glycocalyx, right? I hope I can write down there. Yeah. So glycocalyx so it is around 11 microns thick and it protrudes 50 to 100 nanometers into the lumen. Helps in maintaining plasma and vessel wall hemostasis. And also it's mentioned that it contains negative charge because of presence of lipids and all, it has this negative charge. So glycocalyx, which covers the endothelium, vascular endothelium, it is approximately 11 microns thick, protrudes 50 to 100 nanometers into the lumen, and it maintains plasma and vessel wall hemostasis by preventing aggregation of platelets and adhesion of platelets, right? So that's the reason why you don't find clot formation within the blood vessels. Yes, Virchow's triad, it's VIRCHOW. Good, good, Preeti. So it's option A. Okay. Now let's proceed to the next question. The fifth one. In Philadelphia chromosome, there is option A, translocation between chromosomes 9 and 22, transduction between chromosomes 7 and 21, translocation between chromosomes 8 and 14, none of the above. We have various structural abnormalities in chromosomes, in the number of chromosomes or in the structure of chromosome. So we have different altogether. We'll discuss different abnormalities in a separate session where we can have deletion, where we can have translocation, and also there is a ring formation. So we have some 6 or 7 structural abnormalities, and we'll discuss that with examples. And we have something called as cry-do-chat syndrome, where infant cries like a cat, or infant's cry resembles that of a cat's cry. It's seen in case of gene deletion. We'll discuss all this separately, right? So, translocation between chromosomes leads to Philadelphia. So, Philadelphia chromosome, as you all know, this was first identified in a country called, in US we have this Philadelphia. So, it was identified in Philadelphia first, hence called as Philadelphia chromosome. So, Purvil, how far is Philadelphia from your place? So, this is found in more than 95% of chronic myeloid leukemia cases. So, this is very important. CML. So, in Philadelphia chromosome, there is translocation between long arms of chromosomes 9 and 22, which we discussed in one of the live sessions previously. So there is translocation between long arms of chromosomes 9 and 22. Yes. What about translocation between chromosomes 8 and 14? In case of Burkitt's lymphoma, there is translocation between chromosomes 8 and 14, option C, right? So in Philadelphia chromosome, there is translocation between chromosomes 9 and 22. Okay, Purvi. Okay, it's 4 to 5 hours. Right. Right. So we'll just proceed with the next question. So 6th question. Erythroblastosis fetalis is a condition when there is Rh negative mother and Rh negative fetus, Rh positive mother and Rh negative fetus, Rh positive mother and Rh positive fetus, Rh negative mother and Rh positive fetus. So different combinations altogether. So what is this erythroblastosis fetalis? Erythroblastosis fetalis, as the name itself indicates, we find excessive number of erythroblasts where there is death of an infant also. I hope we can read this right here. Erythroblastosis fetalis, it's also called as HDNB, hemolytic disorder of newborn. So whenever, exactly. So we have unanimous answer. Good. So Rh negative mother with Rh positive father and Rh positive fetus. So there can be this chance for erythroblastosis fetalis. Why is it called as erythroblastosis fetalis? We discussed previously. So why do we say this? So when mother is Rh negative, so there are no antibodies. There are no Rh antibodies in the mother. So as the fetus is Rh positive, the fetal circulation can enter, or the fetal blood can enter into the mother, especially in the 3rd trimester or during delivery time, as a result of which mother is sensitized by these Rh positive cells, and the humoral system within the mother has these memory cells formation, and there is production of antibodies, Rh antibodies against the fetal blood cells. But by the time these antibodies reach the fetus and destroy the RBCs over there, there is delivery happening. So the first baby is safe. There is no issue there. But with the second pregnancy again, in the same case scenario where we have Rh negative mother obviously, and again Rh positive fetus in second pregnancy, now there can be more time for these antibodies to enter into fetal circulation, ultimately leading to fetalis. How? Because these cells, these antibodies destroy the fetal RBCs. As a result, there is anemia in fetus, and bone marrow within the fetus is more stimulated to produce more RBCs in the process, thereby leading to formation of more number of immature cells. So erythroblastosis, that's the reason why we call this as erythroblastosis fetalis. So in first pregnancy there is no issue, but from the second pregnancy, in the same combination like Rh negative mother and Rh positive fetus, there can be lysis of fetal RBC. Hence it's a fatal condition, hence considered as a fetalis, erythroblastosis fetalis, or hemolytic disorder of newborn, HDND. Okay. So in order to overcome this problem, what we do is we prevent mother's immune system from getting sensitized. So we deliver or inject RHD antibodies passively, passive immunity. So passively we deliver RHD antibodies during 28 weeks of gestation. Antibodies are given to mother 28 weeks, that is approximately so 4 7ths, so almost in 7th month, 28 weeks of gestation, that is in the 3rd trimester more or less, or along with that first dose, a second dose is given 72 hours before delivery approximately. So make a note of this, right? I'm sorry, I'm having this throat infection again, so you'll be having those odd sounds. I'm sorry for that. So erythroblastosis fetalis is a condition seen when there is Rh negative mother and Rh positive fetus, also called as hemolytic disorder of newborn. So RHD antiglobulin, it's injected to mother at 28 weeks of gestation and 72 hours within termination of pregnancy, right? Yeah. Now let's move on to the next question. 7th patient. Gene, so 7th question is gene for sex determination. SHH, AZF, HOX, SRY. So which of the following is a gene for sex determination? So, right. Do you have space here? I think we can do it here itself, right? So, SRY gene is also called as testis determining factor. SRY gene is also called as testis determining factor, or it's also called as sex determining region on Y chromosome, SRY, sex determining region on Y chromosome. So it's also called as testis determining factor. It's a DNA binding protein in fact. So genes are again nothing but nucleotides combination. So it's a DNA binding protein which is responsible for initiation of male sex determination in humans. What about other options? We have other options like SHH, AZF, HOX. Just make a note of SHH. SHH gene is involved in regulation of vertebrate organogenesis. And you have AZF, which is nothing but azoospermic factor, which is known to enhance or stimulate sperm production. Azoospermic factor. Right. And then you have HOX. So HOX is mainly a gene which controls the craniocaudal axis. Or it controls the body plan of embryo, or determines craniocaudal axis. You just make a note of these additional points also, right? So SRY, sex determining region in Y chromosome, or it's also called as testis determining factor. SHH is which regulates vertebral organogenesis. AZF, azoospermic factor, sperm production. HOX controls body plan of embryo, craniocaudal axis. Right? Hi Prashanti, a very good morning. Okay, so the answer is option B. So we have our 8th question. Which of the following is not a tumor suppressor gene? So we have options WT1, NF2, PTEN, RAS. So which of the following is not a tumor suppressor gene? Yeah. So it's option D, RAS, which is mainly involved in cell signal transduction. We just mentioned the function of RAS. Cell signal transduction. Right? And WT1, NF2 and PTEN are obviously tumor suppressor genes, or also called as anti-oncogenes. I'll give you a list of some anti-oncogenes, make a note of them, right? So I think we have some limited space here, I'll try to cover here. So various anti-oncogenes include P53, and then you have RB1, WT1, NF2 and also NF1. NF stands for neurofibromin, APC, TSC1, BRCA1, BRCA2, and then VHL. We have a huge list. MSH2, also PTEN, as you can see. So option C is also an anti-oncogene. PTEN, it stands for phosphatase and tensine homolog. Okay, right. So these are some of the anti-oncogens. So you can just make a note of them: P53, RB1, NF1, APC-TSC1, BRCA1 or 2, VHL, NSH2. If your day is not so good, you'll have such patients also. Right. Richa, that's it. That's why I said if your day is not good, you'll have these questions. Anyways, you're not going to, you have certain main things, you can just focus on them, right? So you can have these odd questions. At least if you can note down these questions, and maybe you need not really memorize, but once you go through them repeatedly, at least you can rule the odd one out. So that can be possible, right? Rather than remembering all of them, you can just get familiarized with these terms. Maybe if you have such questions, as you answered RAS, so you don't have RAS, you can be confident in at least ruling out the right answer, isn't it? By eliminating what you know, obviously you'll be ruling out wrong answers, and you'll be getting to one appropriate answer, hopefully. Yes, we'll have a penultimate question, 40. I'm sorry. I have some set of questions. In that it's 40 anyways. So 9th question. Proud fresh. Proud fresh, proud flesh. Okay. Proud flesh. Option A, inhibits epithelialization, promotes epithelialization, no effect on epithelialization, none of the above. So what is this proud flesh? Yes, Sanjay, good. So proud flesh is nothing but exuberant, excessive growth of granulation tissue. And make a note, granulation tissue is considered as hallmark of healing. My teachers used to say during +1 and +2 that whenever a surgeon finds this granulation tissue in the process of healing, he's so excited. In the sense, this granulation tissue means there are numerous sprouting capillaries, plasma cells and other inflammatory mediators also. So it's considered to be hallmark of healing. Proud flesh. So proud flesh obviously inhibits epithelialization. And I've written one word here, if you have observed, CI, contact inhibition. So what is this contact inhibition? You might have come across this term while going through a wound healing chapter, isn't it? It seems to be buffering fine today, right? It's almost buffering, it's showing HD quality. So I hope you'll not have any issues in going through the content which I have written on the board. Yes. So contact inhibition is nothing but whenever you have this, for example, I'm running short of space here. Right, let me just try out here. Whenever there is wound, so you'll have some defect, you'll have epithelium, you'll have connective tissue. So in the process of, you find in case of primary union or secondary union, you'll have collagen fibers deposited all over, and then epithelium starts growing. Let me just represent that with another color. So when epithelium starts covering the defect, as the cells come in contact, they stop growing. So that is called as contact inhibition. As the cells try to come in contact, when they're growing in the process of covering the wound, the moment they come in contact, the cells, there is something called as contact inhibition genetically programmed to prevent overlapping of growth. So contact inhibition is seen in case of your wound healing. I just wanted to discuss that term in this context. So proud flesh inhibits epithelialization. It's nothing but, as Sanjay said, exuberant growth of granulation tissue which prevents epithelialization. So it's like exacerbation. Okay? And treatment, exuberant granulation tissue has to be surgically removed. Okay? So we'll have our final question for today. Yeah. The growth of uterus during pregnancy is an example for. Yes, Richa, very good. Stoppage of growth after contacting with cells, right? So the growth of uterus during pregnancy is an example for hypertrophy, hyperplasia, dysplasia, both A and B. If you go for workouts, if you start lifting dumbbells, you will see muscular growth. So Abhishek, muscular growth is an example for hypertrophy or hyperplasia. Shoaib, you say hyperplasia? Yes, Sanjay. So Abhishek, you think? So there is muscular growth, so there is hyperplasia, increase in cells. You know muscle cells, as you know, muscle cells, nerve cells, heart cells, cardiocytes, they have limited potential to grow, isn't it? So obviously there is hypertrophy. So bodybuilding, muscular hypertrophy. Now, let me give you another example. During puberty, growth of female breast is an example for hypertrophy or hyperplasia. Yeah, good. It's an example for physiologic hyperplasia. Growth of female breast during puberty, physiologic hyperplasia. Because we have something called as compensatory hyperplasia. Now the question is, where do you find compensatory hyperplasia? Yes, Shoaib. So where do you find compensatory hyperplasia? As you mentioned, that's physiologic hyperplasia, true. So where do you find compensatory hyperplasia? Very good. Yes, in case of liver transplantation, or when you go for lobectomy. Yes, so liver has hepatocytes, they have this regeneration potential again. So one example for compensatory hyperplasia is growth of your liver after lobectomy or hepatectomy, partial hepatectomy, right? Now, the growth of uterus during pregnancy is an example for both hypertrophy as well as hyperplasia, right? So it's option B as well as A. It's both A and B. That is, option D is the right answer, and it's a physiologic response, isn't it? In kidney, if one is not working, we will see hypertrophy. As far as I believe, the other kidney which takes up more work or more load, I think it's hypertrophy. Anyways, you have any specific reference to let me know, Preeti. Fine. So these are a set of our 10 questions. So to facilitate better discussion, what we have done is we have shared the same 10 questions, only the question and options without any answer or explanation in yesterday's Google group itself. So from now on, we'll try to have every session in a similar format, every Wednesday morning session, where I'll be sharing you questions prior. You can work out. I mean, it's better if you can practice by yourself and then come for discussion, so that it will be much more useful and relevant for you, right? So we'll be discussing not just the question and answer, but also related aspects pertaining to that question. Yes, thanks for letting me know. There was some issue, I think. Yeah, it's streaming now. Is it fine? Yeah, okay. Alright, thanks. So what we're doing is, like, everyday live session, it's taking a lot of my time. In fact, I'm just spending around 4 to 5 hours during live session, before live session, after live session. So the number of things which have to be done in other aspects, like daily tests, recorded videos, so we're having issues with all of those. So keeping those things in mind, so what we have done is try to concise, at the same time give more quality, but not to compromise on the quality, as I mentioned in one of the previous posts. So you'll have 4 to 5 videos as usual every week, but that will be only on Wednesday, Thursday and Friday evening. Please check out our new poster. And also, we have dispatched special gifts for all the FunFest winners. We have done it a bit late, so you'll be getting them soon, this week itself, as far as I believe. So you have something special in that, so I hope you like it. Anyways, so we're done with this, and today evening again we're going to have another virtual classroom session. I'll let you know the topic if possible, or else if it's a textbook discussion, I'll definitely let you know the topic the before day or the morning itself, right? So we'll just proceed in this format. You want any further modifications or you have any suggestions, drop a mail. And also we're conducting this AIMS mock test, 2008 AIMS mock test on Friday. So the test will be live from 9 PM onwards. All the registered students, you need not apply again, because you'll be having that in your account by 9 PM on Friday. I mean, rest of those who are not registered, the mock test is for free. You can just drop a mail at proudtobedentist@gmail.com, will give you access, credentials, access to that particular test, right? Yes, what to do in last minute revision for AIMS? Just practice papers, as many papers as possible, and think less of it. That's what I can say. And don't touch anything which is new. And most importantly, my personal opinion, also I've seen, stop discussing. Don't have this MCQ discussion pertaining to AIMS. Like you have an AIMS exam, so don't start discussing topics relevant to AIMS, because again, if you're familiar with the topic, you'll feel good. But if you're not familiar, you'll again start having this stress and all. So avoid discussing in the last minute. Prepare for yourself. All that you know, you can just revise quickly. You can just practice few more papers, and you can also write down a mock test. That's all, right? Exactly. Research makes you learn and retain more. That's really true. So that's the reason why, if you can put up more effort in finding out the answers or in understanding things first before coming to discussion or before discussing anything with your friends or anybody, it will be much more better and beneficial for you. I know it's painstaking, but that's more effective process of learning. Okay. Yes. So it's 6:15. We'll stop it now. It's been 1 hour approximately. Yeah. You're welcome. Okay, see you again today evening at 8 p.m. Okay, it's 8 p.m. not 9 p.m. Yeah. Virtual classroom session, I might not be able to tell you the topic before. I mean, if it's a topic based, but if it's textbook discussion, I'll definitely let you know. If it is evening, I'll share the same soft copy in the morning itself, right? Yeah. Okay. Have a nice day. Love you all. Bye.